Hey everyone, welcome back to Dietitians and Nutrition Support. Today we're going to be talking about energy needs. If you've ever taken an MNT class or have seen patients in real life, you are probably very well aware that we are calculating energy needs for basically everyone that walks in the door. And this is so that we can accurately provide calories to support our patients' nutritional needs. So because it's so important for us to be getting those energy needs correct, we have to understand the various ways that we can approach calculating or determining those needs. Today I have two guests joining me to help talk through this topic. First up is Kayla, who's going to give us an overview of direct and indirect calorimetry and some of the use cases as well as limitations. And then second, we have Turner, who's joining us to talk about some of the most commonly used energy needs calculation equations. And finally, once both of them have given us a good overview of how we might approach calculating energy needs, I'm going to take us through two mini case studies that are going to give options for which energy calculator we want to use, and then we'll make a best choice based on the clinical presentation of our case studies. So hopefully this is helpful for you, and let's go ahead and get started.
Hi, my name is Kayla, and so today I will be talking a little bit about energy calculations. So why do we calculate energy needs? Energy needs are a basic characteristic of life. We need to consume chemical energy, which is food and beverages, to power work. Energy is required to maintain homeostasis within the body and to perform all activities associated with life. Something to remember to use as a starting point: calculations are not static. Trying to figure out somebody's energy needs are definitely something that is a dynamic thing. There are alterations in metabolisms that have an impact, burns, whether somebody has inflammation or trauma. And using energy equations and getting a calculation is realistic for a clinical setting. It's a quick way to give us an idea or a ballpark of where to start when we're needing to calculate their energy needs. Direct calorimetry. This measures heat and chemical energy in a room. Also, there's some urea collection that takes place, catching of urine. It's best used in healthy individuals, and most oftentimes it's used in an academic environment. It's not really practical in a clinical setting because individuals must be alone in a room for an extended period of time. So we don't often see this anywhere in a clinical setting, as nurses and doctors and people have to tend to patients. It's also very expensive. So we don't see direct calorimetry used very often unless you are in an academic setting. So indirect calorimetry is the gold standard in the clinical and research setting. It measures inspired and expired air, your oxygen and your carbon dioxide, and it measures exhaled minute volume as well. And the computer usually does the calculation for you when you're using this. It's a machine that is much smaller than doing direct calorimetry. It captures gases for about 30 minutes. So the patient has to be using the machine for 30 minutes of time to be able to measure this. It is definitely more practical in the clinical setting, but things to consider: you do need to have trained individuals. Not everybody can just put a patient on the machine and measure their energy level. It is lower in cost, and it definitely can use it while continuing patient care. So some things to consider about indirect calorimetry: it's good for patients with a lower BMI of under 20.5. Unexplained weight loss is a good one. So you've done your calculations and this patient keeps losing weight, and we're using estimations. Using the indirect calorimetry might be a good option for this patient. Patients that are on the ventilator with high requirements, or you're struggling to wean them off the vent. Another reason to use this. Massive tissue loss from amputations. You think of bilateral leg amputations, might be a good idea to pull out the indirect calorimeter for this patient. And again, patients, you're unable to determine a dry weight prior to admission. A lot of times they come in and their weight is up and they're fluid overloaded. So using the indirect calorimeter for this patient would also be a good idea. Some contradictions are air leaks, patients on BiPAP machines or non-rebreathers, patients on hemodialysis is a contradiction to this, as well as inability of cooperation from a patient. For our patients that are anxious or claustrophobic or demented and they're not able to keep the mask on to be tested for their oxygen and carbon dioxide gas exchange, you may not want to use this on them. Patients with a vent on the vent with a fraction of inspired air or inspired oxygen of greater than 60%, and then extracorporeal membrane oxygenation, aka ECMO. You don't want to use this on patients who are on ECMO. So now that we've talked about indirect and direct calorimetry, which I've mentioned is not always used in the clinical setting, and we don't usually have those machines in most settings we work in. So we're going to turn it over to Turner now, who's going to talk about the different energy equations and how to use them in the clinical setting.
Hello, everyone. My name is Turner. I am a dietitian in Mississippi, and today I will be talking with you about predictive equations for both the healthy population and the critically ill population. So there's a handful of equations that we're going to discuss, and we'll start with the ones for the healthy population. And there's 3 of them, and 2 of them you're probably familiar with. The first one being the Harris-Benedict equation, the second one being the Mifflin-St. Jeor, and the third one being the Livingston equation. Typically, when a dietitian is getting ready to calculate nutrient needs, most of the time a measured resting metabolic rate is not available for us. Therefore, we are using estimates or we are using equations to determine a patient's needs. First one being the Harris-Benedict equation. The Harris-Benedict equation tends to overestimate the resting metabolic rate, and several studies have observed that and validated that. In 2003, there was an evidence review by the Academy of Nutrition and Dietetics that indicates that other equations are more reliable than the Harris-Benedict. For this specific reason, the equation has transitioned from a clinical tool to more of a historical landmark. And I know that many are familiar with the Harris-Benedict. The second one we'll talk about and that you're probably very familiar with is the Mifflin-St. Jeor equation. It originated in 1990. It has been validated in both men and women. The Academy of Nutrition and Dietetics conducted a systematic review, and they found that the Mifflin equation is more favorable than other equations. The accuracy of Mifflin-St. Jeor falls when applied to obese people. For instance, if you have a patient that has a BMI of 30 or higher, you're looking of about an accuracy of 75%. Whereas if a patient has a BMI of 30 or less, has an accuracy of 87%. And then lastly, this one's interesting, and I feel like this one will be new to you, and that is the Livingston equation. It originated in 2005, and the Livingston equation is actually very comparable to the Mifflin-St. Jeor equation. So a few comparable instances. Livingston equation is more reliable for your non-obese patient or your patient that has a BMI less than 20, whereas your Mifflin-St. Jeor equation is going to be more reliable for your obese or severely obese patient. And just give you some percentages that can be compared. For the non-obese patient, the accuracy for the Livingston was 88% compared to Mifflin-St. Jeor, which was 87%. For the patient that has a BMI of less than 20, the Livingston equation had an accuracy of 85%, where Mifflin had an accuracy of 80%. And then when you look at the obese patients, the first obese patient, if for a Livingston, it's about a 69% accuracy, whereas Mifflin St. George is a 75% accuracy. And then for your severely obese patients, the Livingston has a 57% accuracy and the Mifflin has a 68%. So once again, not for you to get lost in the numbers, the Livingston is comparable to Mifflin, but Mifflin has been shown to be more accurate for the obese population, whereas Livingston equation has been more accurate for the normal weight patient or the patient that has a BMI less than 20. Now, when you look at the equations for a critically ill patient, there's a few that we will look at. First, typically, most dietitians, I feel like they are going to use a ratio method with a critically ill patient. And that is actually not a very reliable way to predict resting metabolic rate. Studies have, been conducted on the accuracy of the ratio method. And by ratio method, I mean using 25 calories per kilogram or 30 calories per kilogram. Studies have been conducted, and the accuracy rate of the ratio method is less than 50%. So for the critical population, the ratio method is not reliable and it's not recommended. The other method that we will mention is the Ireton-Jones equation. With the Ireton-Jones equation, it has been found that there is a low accuracy rate in the mechanically ventilated patient or the critical care patient. And the Academy of Nutrition and Dietetics Evidence Library does not recommend the use of the Ireton-Jones equation. Next, the Swinemer equation. It has a very low accuracy rate as well when it comes to predicting the resting metabolic rate. It's accurate about 55% of the time, and it can even cause larger errors that result with a resting metabolic rate 15% above what it should be about 30% of the time. So that one is not recommended by the Academy of Nutrition and Dietetics either. And then lastly, the Penn State equation. You've probably heard of that one before. That one is recommended by the Academy of Nutrition and Dietetics. It is considered very accurate with a morbid obese population, and it even has been shown to have an 80% accuracy for patients that have a BMI up to 80. So that's pretty impressive. However, while Penn State is recommended for the critically ill population, and it has been shown very accurate for the obese population, it's a little less accurate for the population that has a lower BMI. And it has about a 63% accuracy rate for a patient that has a BMI less than 20.5. Kind of a summary for those equations. For the healthy population, the Mifflin St. George is recommended. And some equation that you may not have been familiar with is the Livingston equation, which is comparable to Mifflin. Just know that the Mifflin equation has been shown to be more accurate for the obese population, whereas the Livingston equation has been shown to be a little more accurate for the normal weight population or the patients that have a BMI less than 20. And then for your critically ill patients, the ratio method has about a 55% accuracy, so it's not reliable and it's not recommended. And then the equation that is most recommended for the critically ill population is going to be your Penn State equation. And it's very accurate for patients that have an obese BMI. And it is a little less accurate for critically ill patients that have a lower BMI. So choose wisely, and I'm sure you will, and I hope this helps you.
Okay, so Turner just gave us the rundown of the various different types of equations we can use for our healthy and our critically ill patients, but I thought it'd be helpful for us to actually look at the differences between each of these different types of equations to see what variables are included and how we might be able to calculate these on our own. The first thing I want to touch on is a weight-based calculation. I also will call this a ballparking method. So a ballparking method or weight-based calculation means that we are doing our calculations just based on the body weight of the patient. So in most situations, we're looking at a number of kilocalories or number of calories per kilogram of body weight. Sometimes various folks will choose different types of body weights, like a calculated body weight versus the actual body weight. But when you're actually going to calculate a weight-based estimate, really all you're doing is listing a number of kilocalories and then doing that for each kilogram of whatever body weight you've selected. So a great example of this, and one that's used very frequently in clinical care, is 25 kcals per kilo to 30 kcals per kilo. So you've probably heard this a lot for healthy patients, and that was what we would consider a weight-based calculation. Next up, I want to speak to Mifflin St. Jeor. So Mifflin St. Jeor has two different equations, one for men and one for women. You can see that they're actually pretty similar in terms of what variables are needed to be able to solve through the problem or the equation. And in this case, we're using weight in kilograms, height in centimeters, and age in years to be able to estimate that resting metabolic rate. So again, it's pretty straightforward. You just throw in those variables into the spaces in the equation, and then you just calculate it across. So slightly different values for men and women that will get you a calculated resting metabolic rate. So up next is the Harris-Benedict equation. The Harris-Benedict equation similarly has two versions of it, one for men and one for women. And again, seems very similar. You can look at the equation and you'll notice that we're going to again drop in kilograms for our weight, our height in centimeters, and then age in years to be able to solve this equation across. The last step for our healthy patients is the Livingston equation. This one also has a men's version and a women's version. You can see that we are going to be utilizing only two variables within this particular equation. We're going to be looking at the weight in kilograms, and we're going to be looking at the age in years. You'll see that in the Livingston equation, as compared to the other equations that we've just looked at, that we are experiencing for the first time a value being set to a power. So we're seeing here that the weight in kilograms is going to be to a power. So this is slightly different than what we've seen in the other equations where we're basically just multiplying and adding and subtracting, but just a slight modification for how we will manipulate the weight variable before we continue on with our traditional multiplication, subtraction, that kind of thing for this particular equation. So as you can see, for the healthy patients, for the most part, our equations will have both a men's and a women's version, and we'll also see that we have kind of a range of the number of variables that might be needed for the calculation, from the minimum amount being the weight-based calculation with just one variable of weight being included, all the way to the maximum amount with Mifflin St. Jeor and Harris-Benedict, both including three variables of weight, height, and age. So now that we've looked at the healthy patient equations, let's take a look at those equations that are specifically for patients who are critically ill. Within this category, you may also see those weight-based calculations pop back up. So what I call that ballpark method. These weight-based calculations, again, are literally just utilizing weight, typically in kilograms, to be able to calculate how many calories to provide. So a common one that you might see is like 30 kcals per kilogram. These weight-based calculations are going to vary quite widely because oftentimes folks will just pick either a recommended or sometimes an arbitrary value for calories and then multiply it by the number of kilograms. And again, it can also range in terms of what weight is utilized, if it's an actual weight, an ideal weight, an adjusted body weight. So it can be very widely ranging in those weight-based calculations. The next one we had mentioned is that Ireton-Jones calculation. The Ireton-Jones calculation is pretty interesting because we, for the first time compared to our healthy patients, are seeing just a singular equation that does not include any separation for the sex of the patient. So in this particular equation, they're calculating that resting metabolic rate using a large variety of variables. So you can see here we're going to be utilizing age, we're going to be utilizing weight in kilos, and then you'll see that there are actually three variables, one for sex, one for trauma, and one for burns, in which there is either going to be a value of 1 or a value of 0, depending on whether or not the patient fits the specific qualification. So for sex, you'll see that if the patient is male you would put a 1 right here, and you'd multiply that by the 244. But if the patient was female, you would put a 0 here, and then 0 times 244 would equal 0, so then this wouldn't have any additional value. Similar things will happen for the trauma and burns variables as well. So for this case, trauma, if the patient did have trauma, that would equal 1, and if they didn't have any trauma, that would equal 0. So you would only add on this additional calories if the patient did have trauma. And lastly, for burns, that same situation occurs. If there was a burn present, it would equal 1. If there was no burn, it would equal 0. So if this equaled 0, there would be no additional calories added for the burn. So if you think about this, in a situation where you had a female patient that did not have trauma and did not have burns, that would actually result in the Ireton-Jones equation really being this consistent variable, adding in a multiplication for the age and adding in a multiplication for the weight, and that would be all that you would actually include, because then the rest of these would be 0, 0, 0. And then the last one on our list here is that modified Penn State equation. So for modified Penn State, it actually starts out with utilizing the Mifflin-St. Jeor equation as the baseline. So in this situation, you would calculate the Mifflin resting metabolic rate. You would multiply that here by this 0.71, and then let's look at the other variables that we're going to include here. So this is the first situation where we're actually seeing temperature max and then minute volume included as variables in the equation. So temperature max, or this Tmax, is going to be the maximum body temperature that the patient has had recorded in the last 24 hours, and this will be in degrees Celsius. Next, you'll see that we're also going to be using minute volume as expressed in liters per minute. So this is particularly for patients who are on a ventilator. And remember, because we're including Mifflin as a part of this equation, we're already actually taking into account the weight, the height, and the age of the patient, all within this Mifflin category here, before we're adding on these additional variables of body temperature and minute volume. So now that we've looked through the differences between all of these equations and what kind of variables might be included, let's jump to some quick case studies so we can walk through and see what our best option is for each of these patients for calculating their energy needs. The first mini case I have for us today, we're not going to have a ton of details, but we're basically just going to quickly pick out which is the best equation option for this patient. So our mini case number 1 is a healthy patient. This patient is 39 years old, he's spontaneously breathing, and he has no medical conditions that are leading to an increased caloric need. He currently is ambulatory in the hospital, so he's able to get up and kind of walk around a little bit, but again, he's in the hospital, so he's not really, running laps or anything like that. He is 5 foot 11 inches, he's 180 pounds, he has a BMI of 25.1. So let's talk through our 4 options for how we might choose to calculate the energy needs for this patient. The first choice is that ballpark method. So we're all very familiar with ballparking. That 25 to 30 kcals per kilo of actual body weight is typically used for a patient who doesn't have any medical needs increasing their caloric requirements. So for this instance, you can see the 25 kcals per kilo times the number of kilos gets us this value, and 30 kcals per kilo times his number of kilos gets us this value. So our total range for the days of calories is right here, 2045 to 2454. Our next option is Mifflin-St. Jeor. So Mifflin-St. Jeor has different equations again for males and females. So looking at the male-specific equation, we're going to be able to take all of this kind of baseline equation and just drop in the numbers that we have for this particular patient. So you'll add in the weight in kilos, the height in centimeters, and the age in years, and then just solve it all the way across. So you can see in the second row here that I solved that all the way across. And the total value that you're going to get is going to be that resting energy expenditure, or the resting metabolic rate, some will call it, and the value that we get is this, 1755. Because this is the resting metabolic rate or resting energy expenditure, it doesn't take into account the fact that he is slightly ambulatory and he might be moving around just a little bit. He's not completely bedbound. So in this case, I'm choosing to include a sedentary activity factor, which is 1.3. So saying he needs just a little bit more than if he was laying in a bed all day. So in that case, we'll take our 1755, multiply it by 1.3, and that gives us an estimated 2282 calories per day. Our third option, Harris-Benedict, does also have different calculations for male and female patients. So in this case, we're going to be including those same variables that we saw in Mifflin St. George, and we're just going to treat them a little bit differently. So you see in Harris-Benedict, we also need the weight, the height, and the age in years. So if you add all of our variables into this equation and calculate that all the way across, you'll get a value for the resting energy expenditure of 1832.5 calories per day. I'm going to do the same treatment here by multiplying by the 1.3 sedentary activity factor because, in theory, same guy, still ambulating, so we're just going to keep that consistent. And you can see that the estimate for Harris-Benedict is slightly higher than what we had as an estimate for Mifflin St. George and slightly below kind of the top range of the ballpark method. So I guess you'd say it's in range for the ballpark method as well. Last up on our list, the fourth equation option we have is the Livingston equation. So Livingston also has separate equations for males and females, and so for the male equation today, we're just going to be including values for the weight in kilos and the age in years. So with this, we have put in on our second row, we've dropped in that weight in kilos and that age in years and calculated that across. And all of that gets us to a resting energy expenditure of 1741. Again, we're going to multiply by the sedentary activity factor, and that is going to give us an estimate of 2263 calories per day. So you can see that the range of the ballpark method is actually a lot broader than what we get when we're looking at Mifflin, Harris-Benedict, and Livingston. So Mifflin, Harris-Benedict, and Livingston are all kind of within, maybe about 100 or so, 125 calories from one another. So they're fairly close depending on which one you choose. And then the ballpark method kind of goes, 200 too low and 200 too high compared to some of these. So again, that ballpark method is not our most accurate, so we're going to X-nay that as our choice today. We are not going to move forward with that. We also know that from what Turner described, the Harris-Benedict equation doesn't have the highest level of accuracy either, so we're going to say no to that equation as well. So this brings us down to our two best options for equations, which is Mifflin St. George or Livingston. If you remember, with the Livingston equations, they actually do a little bit better for patients who are considered quote-unquote normal weight, and Mifflin St. George does better for patients who are considered obese. So for this situation, even though the difference is very slight, about 20 calories of difference, we are going to go ahead and opt to use the Livingston equation for this particular patient because this patient is basically within a normal BMI range, and so this might be slightly more appropriate for them and would have a slightly higher accuracy than Mifflin St. George. So next, let's talk about our mini case number 2, which is a ventilated patient. So this ventilated patient is a 64-year-old female. She's in the ICU and she's on a ventilator. We do see that she meets the criteria for malnutrition, so that's something to consider as well, that we are going to want to make sure we are very careful with how we provide needs for this particular patient. I'm going to say that today we're going to go ahead and calculate the quote-unquote goal needs for this patient. So we also have some information here because she's a ventilated patient that we're going to need for our equations. We have information about the temperature max and the ventilation rate for the ventilator. We know that this patient is 108 pounds or 49 kilos. She's 5 feet 5 inches, and her ideal body weight is estimated to be 125 pounds. Okay, so let's start off with our first of our 3 options, that ballpark option. So for this particular patient, I know they're currently ventilator dependent, but in the long run, they also experience malnutrition, and we'll say, because this is my fake made up patient, we're going to say that they also experience some trauma. So for this kind of situation, we're going to want to be providing additional calories to this patient, right? So maybe we would want to pick a ballpark range for something like wound healing or kind of trauma situations. So we might pick somewhere around 30 to 35 kcals per kilo of actual body weight as kind of that goal once we get past the kind of concerns for potential refeeding risk in the earlier parts. So if we pick 30 to 35 kcals per kilo, then we're going to be able to calculate that across multiplying by our 49 kilos, getting a bottom of the range at 1470 kcals per day, and getting a top of the range at 1715 kcals per day. So here is our whole range utilizing that ballpark method. This ballpark method is also where some folks will choose something like ideal body weight or adjusted body weight, depending on the patient, that they might throw in a different value there. Or because it's just a ballpark, you can technically pick any value as a starting or ending value for the range of kcals per kilo. So the second equation we're going to look at for this ventilated patient is the Ireton-Jones equation. This equation doesn't actually have different versions for males and females, but that's because there is a sex variable that you include in the equation. So you'll see here that we're going to include the variables of age, weight, sex, trauma, and then burns. So then we can take all of those variables and complete this big long equation here. So again, we put in years, we put in weight, we said that she was female, so the sex would equal 0. We did say in this case she has trauma, so we're going to say trauma equals 1, and burns equals 0. She does not have any burns. And then if you multiply that and add it all across, you get to a total of 1564 kcals per day. The final equation that we might consider for this ventilated patient is going to be the modified Penn State equation. This equation is particularly used for patients who are on the vent, and it actually utilizes the Mifflin-St. Jeor equation as the baseline for the calculation itself. So the first thing we're going to do here is we're going to calculate Mifflin using the female-specific equation. So that equation utilizes the weight, the height, and the age in years. In our next row here, you can see that all the way solved across to give us a Mifflin value of 1041 kcals per day. So the modified Penn State equation is then going to say, take this Mifflin value, multiply it by 0.71, and then you can also drop in the variables for temperature max and the ventilation rate for this particular patient. In our final row here, you can see that solved all the way across. So we dropped in our Mifflin value, we dropped in the T max and the ventilation rate, and that brought us to a total number of kcals of 1182. So now let's choose which equation is most appropriate for our patient. In basically every situation, again, the ballpark method, particularly for a ICU ventilated critical care patient, is going to have like less than 50% accuracy. So even though I could have picked a different ballpark range, it doesn't really matter. Basically, all ballparks are not super accurate for determining calorie need. So I'm going to say no to the ballpark. Next option was that Ireton-Jones, and for Ireton-Jones, remember earlier Turner was talking about how it's not actually that accurate, and it's particularly not very accurate for patients on the vent. So we're going to say no to using Ireton-Jones for this ventilator-dependent patient. The last is that modified Penn State. So this is actually our #1 choice. So we are going to choose modified Penn State. It's our best option for those patients that are critically ill and that are on a vent. So this is going to be what we are going to move forward with for calculating the energy needs for patient number 2. So this was just a really quick overview of how you might be able to utilize some of these equations for patients that show up into your care. So whether or not they be a healthy patient or they're a critically ill patient, there's definitely a better option in any of these scenarios. There is the best option for what equation you're going to want to move forward with for calculating those energy needs. So now that we've had a chance to work through various case studies and look at different ways that we can calculate patient needs, I just want to bring up the point that even though calculating needs is really important, actually providing adequate needs to our patient is the overall goal. So we have to know what the needs are and then actually provide that nutrition to our patient. So keep in mind that advocating for your patient, pursuing nutrition support if it's needed, and always closely monitoring that patient nutritional status is really essential, and that's exactly what we're here for, is to keep in mind what our patient needs and then actually ensure that it's being provided so that we can help support their overall health. I hope this video has been helpful for you as we've talked through the various ways you can calculate patient needs. If you have any questions, please feel free to leave them in the comments boxes below, and please let us know if you have any ideas for upcoming videos that you'd like to see. Thank you so much for joining us, and we look forward to seeing you next time.